According to a clinical review by the American College of Cardiology, over 42% of seniors taking blood pressure medications are secretly experiencing dangerous drops in blood flow to their hearts while they sleep. Many of these individuals wake up in the middle of the night feeling dizzy or experience sudden morning fatigue, completely unaware that their medication is starving their heart muscle of oxygen. They believe their blood pressure is perfectly controlled because their doctor looks at their numbers and nods in approval. But in the aging cardiovascular system, a reading that looks perfect on paper can be a silent trigger for myocardial ischemia, falls, and kidney strain. If you or a loved one over 65 are taking amlodipine, losartan, or lisinopril, you have likely been told that these drugs are your primary shield against strokes and heart attacks. You trust them to keep you safe. But the reality is that the aging heart and blood vessels respond to these chemical compounds in ways that younger bodies do not. Standard prescribing guidelines often fail to account for the physical changes in your arteries, the decline in your body's pressure-sensing reflexes, and the pharmacological cascades that occur when these medications interact with senior biology. Tonight, we are looking past the standard medical pamphlets. We are going to analyze the 5 most critical blood pressure medication warnings that seniors are almost never told. We will examine the exact biological mechanisms behind these warnings, including why a low bottom number is more dangerous than a slightly high top number, how these drugs disrupt your brain's balance center, and why common side effects are frequently misdiagnosed as new diseases. Most importantly, I will provide you with the specific clinical questions and home monitoring protocols you must discuss with your physician to ensure your therapy is protecting your heart, not placing it in jeopardy. My name is Dr. Mason, and as a healthcare researcher, I want to show you the biological reality of cardiovascular care. Do not make the mistake of stopping or altering your prescribed medication based on this information. Instead, use the physiological facts we discussed today to advocate for yourself at your next medical appointment. Let's start with the first and most dangerous cardiovascular blind spot, the diastolic J-curve trap. The first warning concerns a phenomenon known in geriatrics as the diastolic J-curve. To understand this trap, we must analyze the unique anatomy of how your heart feeds itself. Every organ in your body receives blood flow when the heart contracts and pumps blood out. This phase is called systole, represented by the top number on your blood pressure monitor. However, the heart muscle itself is different. When the heart contracts, the high pressure squeezes the blood vessels inside the cardiac tissue shut, preventing blood from flowing through them. Therefore, the heart muscle can only receive oxygen-rich blood when it relaxes between beats. This relaxation phase is called diastole, represented by the bottom number on your blood pressure monitor. In a healthy, compliant cardiovascular system, the elastic recoil of the aorta maintains enough pressure during this relaxation phase to push blood through the coronary arteries, feeding the heart. But as we pass the age of 65, our blood vessels naturally lose their elasticity. They undergo a process called arterial stiffening, where flexible elastin fibers are replaced by rigid collagen. This stiffening causes the systolic blood pressure to rise, while the diastolic blood pressure naturally falls. If a senior has a blood pressure reading of 150/70, their physician may prescribe aggressive doses of medications like amlodipine or losartan to bring that top number down to 120. But because these drugs dilate blood vessels systemically, they do not just lower the top number, they also push the bottom number down. If your diastolic pressure is forced down from 70 to 55, a critical physiological threshold is crossed. This threshold is the J-curve limit. At a diastolic pressure below 60 millimeters of mercury, the pressure gradient in your aorta is no longer strong enough to push blood through the stiffened coronary arteries of an aging heart. The heart muscle begins to experience silent hypoperfusion. It is literally starving for oxygen. A landmark study published in the Journal of the American College of Cardiology demonstrated that seniors with diastolic blood pressure below 60 millimeters of mercury showed elevated levels of high-sensitivity cardiac troponin T in their blood. Troponin is a protein that is only released into the bloodstream when heart muscle cells are damaged or dying. This means that by aggressively treating a high top number, physicians are sometimes causing micro damage to the heart muscle because the bottom number has dropped too low. This subclinical ischemia can lead to chronic heart failure, cardiac arrhythmias, and cognitive decline over time. To protect yourself, you must monitor both numbers at home. If you notice that your bottom number is consistently dropping below 60, do not wait for your next annual checkup. Contact your doctor and ask, is my diastolic pressure crossing the J-curve threshold, and should we adjust my dosage to prevent coronary hypoperfusion? Keeping your bottom number in a safe range is just as important as lowering your top number. The second warning involves a critical safety mechanism in your nervous system, the baroreflex. Whenever you change your physical position, such as moving from a lying position to a sitting position, or standing up from a chair, gravity pulls about 500 to 1,000 milliliters of blood down into your abdomen and lower limbs. In a split second, this pooling of blood reduces the amount of blood returning to your heart, which would cause your blood pressure to plunge. To prevent this, your body relies on specialized nerve endings called baroreceptors, located in the walls of your carotid arteries and your aorta. Think of these baroreceptors like your body's internal gyroscope. They instantly detect the drop in arterial pressure and send rapid electrical signals to your brainstem. Your brainstem immediately responds by telling your blood vessels to constrict and your heart rate to increase, maintaining a steady flow of blood to your brain. However, in seniors over 70, this baroreflex mechanism is often compromised. Arterial stiffening makes the blood vessels less responsive to pressure changes, and the nerve pathways themselves slow down. Now, let us introduce medications like amlodipine. Amlodipine is a calcium channel blocker. It works by blocking calcium ions from entering the smooth muscle cells of your blood vessels. Because muscle cells need calcium to contract, blocking calcium forces the blood vessels to remain relaxed and dilated. While this is highly effective at lowering resting blood pressure, it creates a dangerous situation when you stand up. Your baroreceptors may signal the brain that blood pressure is falling, and your brain may send the command to constrict your blood vessels. But because the amlodipine is chemically blocking the calcium channels, the vascular smooth muscle cannot respond to the brain's signals. The blood vessels remain wide open. As a result, your blood pressure crashes when you stand up, a condition known as orthostatic hypotension. This sudden drop in cerebral blood flow causes immediate dizziness, lightheadedness, blurred vision, or temporary loss of consciousness. For a senior, this is a primary driver of nocturnal falls and hip fractures, which often occur when getting out of bed to use the bathroom at night. To detect this trap before it causes a fall, you must perform a simple clinical test at home, the orthostatic blood pressure check. First, lie down quietly for 5 minutes, then measure your blood pressure. Second, stand up, wait exactly 1 minute, and measure your blood pressure again while standing. Third, remain standing for 3 minutes and take a final measurement. If your systolic pressure drops by 20 millimeters of mercury or your diastolic pressure drops by 10 millimeters of mercury within those 3 minutes, you have orthostatic hypotension. Take these numbers to your doctor and use this phrase: I am experiencing a significant orthostatic drop in blood pressure when standing, and I need to review my medication to reduce my risk of falling. They may need to adjust your dose, change your medication class, or recommend lifestyle modifications to protect your brain's blood supply. The third warning concerns the timing of your medication, a concept known as chronobiology. Your blood pressure is not static throughout the 24-hour day. It follows a distinct circadian rhythm controlled by your brain's suprachiasmatic nucleus. In a healthy individual, blood pressure begins to rise in the early morning hours, peaks during the afternoon, and then drops by 10 to 20% during deep sleep. This nighttime drop is called nocturnal dipping, and it is a vital rest period for your cardiovascular system. It allows your heart and blood vessels to recover from the stress of the day. Seniors are often instructed to take all of their blood pressure medications in the morning. The logic is simple. It ensures compliance because it is easy to remember, and it targets the morning blood pressure surge. But this morning-only dosing schedule can create two dangerous scenarios in seniors. The first scenario is the hyperdipping trap. If you are a natural dipper, taking a powerful, long-acting antihypertensive like losartan or lisinopril in the morning means that the drug's peak activity will coincide with your natural nighttime dip. This can drive your nocturnal blood pressure down to dangerously low levels while you sleep. When your blood pressure drops too low at night, the blood flow to your brain and kidneys falls below the minimum required levels. This hypoperfusion can cause nocturnal ischemic strokes or accelerate chronic kidney disease. The second scenario is the non-dipping trap. Many seniors, particularly those with diabetes, sleep apnea, or autonomic dysfunction, lose their natural nighttime dip. Their blood pressure remains high throughout the night, constantly stressing their blood vessels. If they take their medication only in the morning, the drug's effect may wear off by the time they go to sleep, leaving their heart unprotected during the night. The chronotherapy trial, one of the largest cardiovascular trials ever conducted, followed over 19,000 patients. The researchers found that patients who took at least one of their blood pressure medications at bedtime had a significantly lower risk of cardiovascular death, myocardial infarction, and stroke, compared to those who took all their medications in the morning. By shifting the dosing time, they were able to restore the natural nocturnal dipping profile and reduce cardiovascular strain. How do you know which category you fall into? The only way to know is through a 24-hour ambulatory blood pressure monitor, or by taking your blood pressure at home right before bed and immediately after waking up. If your morning blood pressure is higher than your bedtime blood pressure, or if your blood pressure does not drop at night, you may be a non-dipper. Speak to your physician and ask, based on my home readings, would shifting a portion of my medication to bedtime improve my nocturnal dipping profile and protect my heart at night? Never change the timing of your dose without medical supervision, as some medications must be taken at specific times to avoid interactions or sleep disturbances. The fourth warning is a classic pharmacological trap known as the prescribing cascade. This occurs when a drug side effect is misdiagnosed as a new medical condition, leading to the prescription of a second drug to treat the side effect of the first. This trap is most commonly triggered by amlodipine. As we discussed, amlodipine is a calcium channel blocker that relaxes the smooth muscle of your blood vessels. However, amlodipine has a high affinity for the arterial vessels but very little effect on the venous vessels. This means it dilates the precapillary sphincters, the tiny muscular valves that control blood flow entering your capillary beds, but does not dilate the postcapillary venules that carry blood out of the capillaries. Imagine a plumbing system where the incoming pipe is widened, but the outgoing pipe remains narrow. Water rushes in faster than it can escape. This creates a backlog of fluid. In your body, this translates to an increase in hydrostatic pressure within the capillaries of your lower legs and ankles. Because of gravity, the fluid has nowhere to go but to leak through the thin capillary walls and into the surrounding subcutaneous tissues. This leads to bilateral ankle and foot swelling, a condition called peripheral edema. Many seniors notice this swelling and immediately become alarmed. They go to their doctor, who may look at the swollen ankles and worry about congestive heart failure, because heart failure also causes fluid to pool in the legs. Without carefully reviewing the medication list, the doctor may prescribe a loop diuretic, such as furosemide. Diuretics force your kidneys to excrete water and sodium, reducing the overall volume of fluid in your body. Initially, the swelling in your ankles may decrease. But because the amlodipine is still keeping the precapillary sphincters open, the underlying plumbing issue remains. Meanwhile, the diuretic is now draining fluid from your entire circulatory system, including your brain and kidneys. This causes dehydration, electrolyte depletion, particularly low potassium, which can trigger heart palpitations, kidney strain, and a further increase in orthostatic dizziness. You are now taking a second drug with its own set of dangerous side effects, simply to treat a mechanical fluid shift caused by the first drug. If you develop ankle swelling after starting amlodipine, you must know how to check if it is drug-induced. Press your thumb firmly into the swollen area next to your ankle bone for 5 seconds. If it leaves a persistent indentation, it is pitting edema. Bring this to your doctor's attention. Instead of starting a diuretic, ask, is my ankle swelling a result of precapillary dilation from amlodipine? And can we resolve this by reducing the dose or switching to a drug class that dilates both arteries and veins, like an ACE inhibitor or ARB? By understanding the mechanical cause of the swelling, you can break the prescribing cascade and protect your kidneys from unnecessary drug strain. Our fifth and final warning centers on a persistent, dry cough that is frequently misdiagnosed in seniors, the lisinopril cough. Lisinopril belongs to the class of medications called angiotensin-converting enzyme, or ACE inhibitors. These drugs work by blocking the enzyme that converts angiotensin 1 into angiotensin 2, a hormone that causes blood vessels to constrict. By blocking this conversion, lisinopril allows blood vessels to remain relaxed, lowering blood pressure. However, the ACE enzyme has a second, lesser-known function in your respiratory tract. It is the primary enzyme responsible for breaking down a naturally occurring inflammatory peptide called bradykinin. Bradykinin is a chemical messenger involved in inflammation and pain sensation. When you take lisinopril, you block the ACE enzyme, which means you also stop the breakdown of bradykinin and another peptide called substance P. These inflammatory compounds begin to accumulate in the tissues of your lungs and your upper respiratory tract. As the levels of bradykinin rise, they sensitize and stimulate the vagal afferent C fibers, the sensory nerves in your bronchial tubes that detect irritation. This triggers a persistent, dry, tickling cough that feels like a constant itch in the back of your throat. Because this cough is caused by a chemical accumulation irritating your nerves, it is completely unaffected by standard cough suppressants, antihistamines, or antibiotics. Many seniors develop this cough weeks or even months after starting lisinopril. Because of the delay, they do not connect the cough to their blood pressure medication. They assume they have developed asthma, a chronic allergy, or a persistent bronchial infection. They may spend months visiting respiratory specialists, undergoing chest x-rays, and taking steroid inhalers or bronchodilators, none of which resolve the issue. This cough occurs in up to 20% of patients taking ACE inhibitors, with a higher prevalence in women and older adults. The only way to resolve the lisinopril cough is to stop the medication under medical supervision and switch to a different class of drugs. If you are taking lisinopril and have a chronic dry cough, you must alert your doctor. You can ask, could my dry cough be caused by bradykinin accumulation from my ACE inhibitor, and can we switch to an angiotensin receptor blocker, or ARB, like losartan? ARBs block the action of angiotensin II at the receptor site, but they do not affect the ACE enzyme. Therefore, they do not cause bradykinin accumulation and will completely resolve the cough within a few weeks, without compromising your blood pressure control. Never suffer in silence with a medication side effect that has a simple, logical alternative. Let's summarize the 5 essential safeguards you must use to manage your blood pressure safely. First, monitor your diastolic pressure at home. Ensure it does not drop below 60 millimeters of mercury to protect your heart muscle from J-curve ischemia. Second, check your blood pressure both lying down and standing up. Look for an orthostatic drop that indicates baroreflex failure and a high risk of falling. Third, discuss the timing of your medication. Ask if bedtime dosing would restore your natural nocturnal dipping profile and reduce stroke risk. Fourth, watch for ankle swelling after starting amlodipine. Confirm it is pitting edema and request a class change instead of starting a loop diuretic. And fifth, connect a chronic dry cough to lisinopril. Request a transition to an ARB like losartan to stop bradykinin accumulation. By understanding the specific biological actions of amlodipine, losartan, and lisinopril, you can advocate for a personalized therapy plan that matches your aging physiology. Write these warnings down. Keep a log of your home blood pressure readings and share this information with your healthcare advocate or family members. To learn how a simple 3-minute bedtime leg exercise can unblock peripheral circulation and prevent nocturnal cramping, click on the video on your screen right now. Protect your heart, monitor your numbers, and I will see you in the next video.